was the reason that we put up and termed it abnormal low and high voltage complexes. So whenever you read an ECG as a physician, so whenever I prepare this presentation thinking what I did when I was doing my general medicine, the most striking feature of an ECG or 12-lead ECG would be whether you're looking at a low voltage complex or a high voltage complex, whether you're looking at small complexes or large complexes, whether you're looking at small P waves, large P waves, small R waves, large R waves. Low voltage, that is what we call low and high voltage complexes. So that is the most striking feature whenever you see an ECG. That, of course, you have to read an ECG in a systematic manner. You'll have to start with the P waves, you have to look at the rate, the axis, and things like that. But still, when you look, what strikes you is the low and the high voltage complexes. So we move on to the low voltage complexes first. So you're aware, many of you know, how they define this criteria for low voltage. It's usually less than 5 mm in the lib leads and less than 10 mm in the precordial leads. It's 10 mm in the precordial leads, which means 2 large boxes, and 1 small box in the limb leads. So I was also trying to get into the literature to find out who put up this criteria and what is this criteria. Is it again named after someone, or was it studied or something like that? But what I found that this criteria was not laid by anybody. It was just being followed over the years as a matter of convenience, that 1 box 5 mm and 2 boxes are 10 mm. And chest leads, everyone knows chest leads is more representative of the QRS voltages, hence it is 2 boxes. Anything more than 2 boxes or less than 2 boxes in the chest leads is going to be low voltage, or anything less than 1 box in the limb leads is going to be low voltage. There was one large study a decade back which reported ECGs and showed the differences in the voltage complexes according to the gender and according to the age. What they found was the QRS, the mean QRS voltage complex, usually peaks around the 3rd decade, both males and females, and progressively decreases in voltage later on. Again, the voltage complexes tend to be of lesser voltage, smaller complexes in females, obviously because of the higher fat content in the anterior chest wall. Hence, you have to consider this before making a diagnosis of a low voltage or high voltage, and you need not really stick to that criteria of 5 mm and 10 mm. You have to consider or take into account the age, the gender differences, and things like that. So this transfer section has been put up to make you understand that myocardium is what that determines the QRS voltage, in addition to some extra cardiac factors. The chest leads, when they are placed on the chest, and there is intervening tissue between the electrodes and the myocardium. Right outside the heart, you have the pericardium. Then you have the lungs. You can see the lungs. When not inflated, when the lungs are not really inflated, they do not intervene. But when they are inflated, like in case of an emphysematous lung, they can get in between the measuring electrode and the myocardium, hence they can reduce the voltage. And the tissue, the anterior chest wall as such, and that's why females have a lesser voltage. And before that, you must be aware of this DPS criteria, which is poor R wave progression. Any R wave less than 3 mm in V3, lead V3, that was DPS quoted as a poor R wave progression. It is basically the transition occurring a little late. So pericardial effusion, lung pathologies like pneumothorax, emphysematous lungs can intervene between the electrodes and the myocardium, resulting in low voltage, and obesity, chest deformities. So those are the extra cardiac factors. So basically you divide them into cardiac and extra cardiac factors. So cardiac factors is direct loss of viable myocardium, what is called a cardiomyopathy, disease of the myocardium. So any cardiomyopathy and ischemic etiology, like a coronary artery disease, or an end-stage dilated cardiomyopathy, or hypertrophic cardiomyopathy patients who have reached their end stage, the heart has dilated, all the muscles have started regressing, and it is all, there is a loss of the myocardial tissue. All these can result in a low voltage. And when there are infiltrative disorders, like you replace the myocardium generates the voltage. If myocardium is replaced by some other tissues, like amyloid infiltration of the heart, hemochromatosis, mixed matters like mucopolysaccharide deposition within the heart muscles, again they can obscure the QRS voltage. So let us start looking at some ECGs. So as Dr. Ullas was telling, all the ECGs are going to be abnormal from now on. So the striking feature straight away is sinus tachycardia. In addition, you can see alteration in the voltage of complexes. So electrical alternance. And obviously there is low voltage complexes. In AVL, you barely see a voltage and the lead AVL. And if you look at a little more carefully, I will take you to the rhythm strip below. You may appreciate, you can appreciate, in fact, a PR segment depression. PR segment depression, you can appreciate when you take into account the isoelectric line preceding it, the TP segment preceding it. So this combination of factors, low voltage, electrical alternance, tachycardia, sinus tachycardia, and PR segment depression usually suggest a pericardial pathology. And that pericardial pathology, which can cause a low voltage complex, you know now, is a pericardial effusion. This ECG is from a patient with a large pericardial effusion. This is another ECG of a patient with, again, a pericardial effusion showing low voltage complexes, especially in the limb leads. So you should also see the history that's written on the ECG. You can get clues from the age of the patient and some other history that you can find written on the ECG. So this was an obese, hypothyroid female. There's no wonder that the complexes are of low voltage. In addition, the patient presented, of course, with an delayed presentation of an inferior wall myocardial infarction. You can see the changes in the inferior leads. Q waves with ST segment changes, ST segment elevation. So this ECG, so what is marked initially, what you can pick out is a low voltage complex lead, something the problem in lead 1 looks like, but it's extremely low voltage in lead 1. Lead 2, you can see the markedly enlarged, the peaking and tall P waves suggesting right atrial enlargement. The P wave axis is again rightward. So rightward P wave axis, right atrial enlargement. You can see the R wave progression. Again, your DPS criteria, that's poor R wave progression. You barely see any, that's a late transition of the R waves. So this combination of a rightward axis of P waves, this is a classical ECG of a P pulmonale, right? So this is a cord pulmonale. The patient had a lung pathology. This is from a patient of an emphysematous lung. Then emphysematous lung resulting in cord pulmonale, and you have these low voltage complexes as a result of those emphysematous lungs. A patient with pneumothorax, good voltage complex in the limb leads looks like, but in the chest leads, there are barely any voltage. It just means there is some problem in the chest, in the intervening space between the chest and the limb leads, in the chest and the chest leads and the heart. So this was a patient of pneumothorax. After putting the intercostal drains, you can see that the voltage complex are back to normal. Again, the patient has sinus tachycardia because obviously he's just recovered from a pneumothorax. This ECG is again very classical. You have a sinus bradycardia, low voltage complex, T wave inversions. This is a triad of T wave inversions, low voltage complexes, sinus bradycardia, and when patient, clinically, if you see the patient is in the altered sensorium and a diminished sensorium, you have to suspect mixed edematous coma, mixed edema, severe hypothyroidism. So after giving some thyroxine, the heart rate improves, but the low voltage complexes still continue to be there, obviously because chronic hypothyroid state results in that mucopolysaccharide deposition within the myocardium. So you have these low voltage complexes. Here, an 81-year-old male, again the history, this was a patient of, known patient of coronary artery bypass surgery, had come with congestive heart failure. low voltage complexes in the limb leads. All you can see is some Q waves even in lead 1, 2, and you can see the chest leads again, QS complexes, persistent ST segment elevations. So this was a patient of an ischemic cardiomyopathy with low voltage complexes. This, you can see that this is one of those interesting ECGs, an 18-year-old female with low voltage complexes. Throughout, low voltage complexes. This, one of my junior registrars was even confused. He was asking me, this looks like, you can see the rhythm strip. He told me this looks like a junctional rhythm with retrograde P waves that he could see. Hope you can appreciate that, but you will have to carefully analyze this in relation to the other leads also. I will take you to lead 1. You can see the P wave, and you can see the QRS complex. You have to line the P waves. If you align the P waves in line, you'll understand how lead 2 P waves look like. In lead 2, the P waves are in fact larger in size than the QRS complex, right? So this is in fact a P wave preceding the QRS complex, and not a QRS complex followed by a P wave. And this is what low voltage complexes can do to an ECG. And if you're not aware that you're dealing with a low voltage complex, you will be surprised. So this was a patient of dilated cardiomyopathy, hardly any myocardium left, fully end-stage dilated cardiomyopathy. This patient was, in fact, did undergo a transplant at our center later on. So this was a case of dilated cardiomyopathy with low voltage complexes. So this I put up because there are a lot of things in this ECG. So when I did my general medicine, my friend always used to get this diagnosis of dilated cardiomyopathy right on the ECG. I used to ask him, how do you get this DCMP correct on the ECG? And his answer was simple. He says, when there are so many changes in the ECG and the patient is sick, then that is dilated cardiomyopathy. And whatever signs he used, but later I found out, yes, dilated cardiomyopathy does cause a lot of changes in the ECG. You have intraventricular conduction delays, you have QRS changes, low voltage complexes. You can even have discrepancy in the low voltage complexes, QS pseudo-infarction patterns, STT changes, and so many things you can have in dilated cardiomyopathy. This you can see almost a pseudo-infarction pattern. This we call a pseudo-infarction pattern in the limb leads, 2-3 AVF. Easily anyone would say this is an old inferior wall myocardial infarction looks like. But again, you have to consider the low voltage complexes, take into account the history of the patient, examine the patient, and here this patient was in fact a case of cardiac amyloidosis. You can see how the amyloid has infiltrated the myocardium, what we call the speckled appearance in classically in an echocardiogram. So the amyloid infiltration of the left ventricular myocardial wall. So the thickness looks preserved of the left ventricular myocardium. However, they are not the muscle tissue. They are all being replaced with the amyloid tissue. Hence, you have these low voltage complexes. So now we move to the high voltage complexes. So as we have to keep in mind, the QRS voltages is contributed by the myocardium. So any high voltage complex is likely to be a pathology. There are very less causes of pseudo high voltages that we would see again. But when you have a high voltage complexes, you should always, almost always, you have to think of a pathology most of the times. You have to rule out a pathology, in fact. So pathology could be a right ventricular. Maybe you're dealing with the right-sided leads, V1, V2, show tall R waves. It means you're dealing with a right ventricular hypertrophy. And if it is more on the left-sided leads, then you're dealing with a left ventricular hypertrophy. Again, whenever you see an ECG of hypertrophy, you should try and attempt to see if that could be a pressure overload type of hypertrophy or a volume overload type of hypertrophy. So just to make you understand what pressure overload, volume overload, this is how the heart would look like. On the left side of the screen, that's how a pressure overloaded heart would look like. A small cavity, severely thickened the left ventricular walls. And on the right side of the heart, eccentric remodeling, what we call the eccentric remodeling of the heart, dilated. The heart walls are relatively, in fact, even thicker than the normal heart, but it is an eccentrically and dilated heart, that's it. So these criteria for right ventricular hypertrophy, I'm not going to explain each of them. All of these are available in the books. So all you need to understand, whenever you look for tall R waves in V1, you should also look at deep S waves in V5 and V6 because they are diametrically opposite. So even if you do not find tall R waves in V1 or V2, and if you find deep S waves in V5 and V6, you should think about right ventricular hypertrophy. This same stands true for left ventricular hypertrophy also in the other direction. Again, right ventricular hypertrophy could be, pathology could be the valvular lesions, pulmonary stenosis, pulmonary hypertension. Pulmonary hypertension, again, you know, can be because of the left side pathology itself, like the mitral stenosis, which is so common in our country, like pulmonary pathologies, and volume overload. Pre-tricuspid shunts. When you talk about right ventricular volume overload, you have to think about pre-tricuspid shunts, which could be most commonly it is an atrial septal defect. It could also be in anomalous pulmonary venous connections. So this slide was purposely put up because, clinically actually we do not classify right ventricular hypertrophy every time as a type A, type B, and type C. And I know all the cameras will be up for this particular slide because this question is usually asked in the exams. Especially the older examiners would always ask this question. We used to prepare answers for that question. So what type of hypertrophy is this? This is a type A, type B, or type C. So it was basically the CHORS classification who gave this classification of type A RVH or type B and type C RVH. Not much of clinical utility nowadays, but still you have to know this. And again, I'm not going to explain all of these. So rather let me show some ECGs. So what you can find in this ECG, you can see the mean frontal QRS axis, which is shifted right. So right axis deviation number 1. Number 2 point, you can see tall R waves. In fact, what you call it's a QR pattern almost, a QR pattern in V1 and V2. And you can have T-wave inversions. What you see is a T-wave inversions in the anterior chest leads. So this is almost a right ventricular hypertrophy with a strain pattern so it's a pressure overload type of right ventricular hypertrophy with a right axis deviation. Usually, with considering this was an young age boy, this turned up to be a severe pulmonary. This is usually a valvular pathology, severe pulmonary, valvular pulmonary stenosis, this was. This was one of the patients of atrial septal defect, where you can see the classical RS R dash pattern in V1, again a rightward axis. This patient, this ECG again very, very common in our country. You can see the predominant negative terminal forces in lead V1, such of left atrial enlargement. If you have left atrial enlargement with a right ventricular hypertrophy, it's mostly a mitral valvular pathology. Here in this case, it's a mitral stenosis. And here, what you see is right atrial enlargement. Again, you can see the peaked R waves, the tall and peaking R waves in lead 2. And again, the R waves are sharp and tall in amplitude in V1 as well. So right atrial enlargement with right ventricular hypertrophy. This was a case of pulmonary artery hypertension. So the voltage criteria for right ventricular hypertrophy does not hold good when you have a bundle branch blocker, especially right bundle branch block. The criteria differs. The tall R wave, usually the cutoff of 7 mm that is laid, differs. Here, in the case of a right bundle branch block, the criteria is different. Here you have the voltage criteria increases. Something more than 15 mm you consider as right ventricular hypertrophy. R dash more than 15 mm in V1, that is in the presence of a right bundle branch block, then only you consider right ventricular hypertrophy. Again, you look for that proxy markers of right ventricular hypertrophy, that is the non-voltage criteria, like the right axis deviation, presence of P pulmonale. These are all proxy markers or additional or corroborative findings that can help you make the diagnosis of right ventricular hypertrophy. So we move to LVH. So as I told you, you look for tall R waves in the lateral chest leads. That's where the left ventricle is, V4 to V6, V4, V5, V6. And correspondingly, the anterior chest leads would have deep S waves. Again, there are non-voltage criteria, which is very important. In fact, Dr. Ullas is going to give a talk next month on non-voltage criteria of left ventricular hypertrophy. This is an exclusive topic by itself, where you need to understand, in the absence of, not all times you can have this voltage criteria satisfied. In the absence of a non-voltage criteria, voltage criteria, you need to dwell on these non-voltage. The Romhild-Esther scoring system was again incorporated all of these non-voltage criteria as well as the voltage criteria in order to improve their sensitivities. So in case of a pressure overload situation, it stresses the conduction system, the left side. So that results in a left anterior hemiblock pattern. Hence your axis shifts, left axis deviation. That results in a left axis deviation. STT changes, left atrial enlargement, increase in the activation time, what we call the ventricular activation time of more than 40 So these are the non-voltage criteria for left ventricular hypertrophy. As I told you, there are many scoring systems. What we commonly follow is the Sokolov-Lyons criteria and the Cornell's voltage criteria. Sokolov-Lyons criteria have a very high specificity. This is just very commonly followed. Everyone must be aware of this. A deep S wave in V1, in that you add it to the R wave in V5 and V6. If it totals up to more than 35 mm, that satisfies the left ventricular hypertrophy criteria. Again, you also need to remember the Cornell voltage criteria because it has a reasonably better sensitivity and balancing it with specificity as well. The total or the diagnostic accuracy is better for the Cornell voltage one. So again, for your exam purposes, you need to remember all these things. So they look at the R voltage in AVL and the S voltage in V3. And again, according to the gender, 28 mm cutoff for men and 20 for women. So the pathologies for left ventricular hypertrophy, as we have discussed, it could be a pressure or a volume overload. Pressure overload, you have to always think about the valvular pathologies, the subvalvular pathologies, hypertrophic obstructive cardiomyopathy, and the supravalvular pathologies, the coarctation of aorta or a systemic hypertension. And volume overload situations, you have to think about shunts, some left to right shunts coming back to the left ventricle, like the ventricular septal defect, patent ductus arteriosus, and the regurgitation, valvular lesions, both the regurgitation lesions. So this is a 70-year-old male, diabetic, hypertensive. Clearly, there's a left axis deviation. You can note Q waves in one AVL and the slow upslurred R wave in AVL. So this is a left anterior hemiblock. The QRS almost satisfies that of a complete left ventral branch block, but I'm not going into those details. So, and you can see the tall R waves in V5, V6, deep S waves in V2, V3, STT changes. So this patient is a long-standing hypertensive with all these changes of left ventricular hypertrophy on the ECG, which includes the left axis deviation. This patient was one of those patients of obstructive hypertrophic cardiomyopathy. So if the R waves you can appreciate better on lead V4, and the same thing in V5 and V6, the tall R waves and STT changes. Yeah, I'm going to this ECG straight just a minute. So I just skipped a few more pathologies of left ventricular hypertrophy because we have dwelled on that. So in presence of a left bundle branch block, again the diagnosis of left ventricular hypertrophy changes. Your criteria changes. Yeah. So the criteria in the presence of left bundle branch block use these criteria. The voltage criteria changes. Again, as you had visited the right ventricular hypertrophy and left ventricular hypertrophy, your voltage criteria increases. Rather than the 35 mm, here it is 45 mm. This was one of our patients of hypertrophic cardiomyopathy, our patients. What you can observe is a left anterior hemiblock pattern. And as I told you, in the left anterior hemiblock pattern, the criteria changes. You look for alternate things. Like here, you can see, observe the deep S waves in lead 3, which are more suggestive of left ventricular hypertrophy in these patients, though there were not those characteristic R waves in V5 and V6. However, this patient of hypertrophic cardiomyopathy, after the surgery, landed up in a complete left bundle branch block, which usually you do expect in these patients. So I'm just moving to a few more slides of biventricular hypertrophy. You diagnose biventricular hypertrophy when you have left ventricular hypertrophy with a few features of right ventricular hypertrophy, like the right axis deviation, or you have features of right ventricular hypertrophy, tall R waves in V1, and the most classical example is the Katz-Vachel phenomenon in ventricular septal defect. So directly I'll show only one ECG of ventricular septal defect. This particular one, we can see the equiphasic, large equiphasic complexes in V2 to V5. So these are the equiphasic complexes. This satisfies the VSD criteria. So that was one example. I did not show the other examples of biventricular hypertrophy. So I'm just concluding with a few more slides on pseudo-abnormal voltages. This particular ECG is from an 18-year-old male who is an athlete. So these athletes, being a young and a male, they do have a physiological hypertrophy of the heart, what you call physiology. It's not a pathological hypertrophy of the heart, it's a physiological. Again, there are echocardiographic criteria to classify them, when you classify them as pathological or not, but this was a physiological. So you do expect such high abnormal voltages in young males and especially in athletes. So this particular ECG, you have a tall R wave in V1 and a tall R wave in V2. This particular patient had a history of palpitations, and again you can see the age, a 24-year-old male. So a 24-year-old male with tall R waves in V1 and V2, apart from right ventricular hypertrophy, if it is a structurally normal heart, you should think about other things. And one of the important things that you have to think about is, here in this case, a delta wave. So if you carefully note, the PR is in fact short in V2 and V3. PR is short, and it is an upslurred, slowly climbing R wave. So this is a delta wave. So this patient had a left-sided accessory pathway with history of palpitations, and he had this orthodromic AV reentrant tachycardia. So this is the last ECG that I'm going to show you, an abnormal ECG with low voltage complexes. So you'll have to come up with the diagnosis. Low voltage complexes, and so I've showed you several of them, and you'll have to try and tell me what this is. Yeah, I got the answer from one of them. I'm happy. So I got the answer from one of them. It is the problem with the standardization. You should note, because after seeing of all these things, you forget the standardization. So this was in fact wrongly taken with a half standardization, or you should understand that the ECG machines nowadays, they are in the auto gain mode. For some reasons, it is in the auto gain thing, they switch it on, and it may automatically shift to one half standardization, or it may increase the standardization for some reasons. So you always start with the standardization before classifying it as a low or a high voltage. So we started with the criteria for low voltage. We saw some causes, some examples of low voltage complexes, RVH, LVH, and bundle branch block. It was to highlight that the criteria, voltage criteria, does not hold the same in presence of bundle branch blocks. We saw very few examples of pseudo-abnormal voltages. Thank you.